Okay, everyone, let's get started. So welcome to our January board meeting. I hope you all had a great Christmas and enjoying your new year and it all went well. And we can chat over a coffee, all the parties you've been to and all the stories you want to share or you don't want to share. That would be great. In terms of some welcomes and apologies. So Jodie, welcome back. So it was, I think we had Debbie briefly.
And she will be again.
She will be again.
Just a clash with our board.
Oh, okay, fine. All right. So, welcome to Jodie. We've got some apologies from Nigel, Neil, and Susan. And just to alert everyone who's not aware, Paul Masters, who was the chief executive of the Council of the Isles of Scilly, of course, has retired now. So we will be joined by somebody called Russell Ashman. I've not met Russell yet. Oh, okay. Lots of nodding, which is looks great. So he's obviously well known and well respected, which is lovely. But at the moment, I'm just looking on the call. I can't quite see whether Scott is here yet. Oh, Scott Fuller on the call.
Yes, I'm here.
Welcome, Scott. Scott is deputising on behalf of Russell, I assume now, or what was Paul. So up on the screen, and I think we've got Molly, who's standing in on our company secretary front, is on the call, and we have Jess taking the minutes. So we're good to go, everyone.
Sam's not here.
Oh yes, and our CFO has a mechanical problem with his car, so he's currently residing in a t-shirt somewhere in this freezing cold, somewhere waiting for someone to come and help. So
the electric car's not working in the cold temperatures.
Yeah. So he's on his way. Okay, everyone. So let's move on. Declarations of interest. Anything that anyone wants to raise relating to the meeting? No. All right. Thank you. There are no questions from the public, is my understanding. Very good. So if we can move to the approval of the minutes of the meeting, I'm not going to. Oh yes, please.
Just a quick comment on page, I think it's page 5 of 16 of the minutes, under the workforce section. It notes that the cost of industrial action so far for the 40 days incurred is about a financial value of £1.2 million. I don't think that's correct, and I don't recall that update having been given. The total financial cost of direct costs so far, excluding the December and the January industrial action, is 4.5 million. And the lost income is 2.4 million. So the net total cost of industrial action so far up to the end of November is about 6.9 million. So I wasn't sure what the 1.2 referred to.
Okay.
Chair, if I could just offer, I think it might be the national figure, which was actually 1.2 billion, would be my observation.
Makes sense, doesn't it?
Makes sense.
Yeah. So should we just move the M to the B? Yeah. Thank you very much for that addition, Andy. Any other changes or factual accuracy from the minutes? No? Happy for me to take those? Yep, done. Thank you very much. Those done. Molly and Karen, are there any of the actions that are outstanding that we're not capturing in the discussion that you want to pick up now?
I don't.
No, Molly, anything that you want to pick up, or should we catch it up through the agenda?
Through the agenda, please, Chair.
Lovely. Okay, thank you very much. So moving swiftly on, I'm going to take as read my chair's report, unless there's anything you want to tease out of that. No, very good. Thank you very much. So, okay, a verbal update, please. Sorry, yes.
Just on Chair's report, just a quick clarification, because I think you noted that there was going to be an update of the health and wellbeing strategy. It's not going to be rewritten and reproduced, just for clarification. It's around a review of its implementation, which I think is about keeping the strategy, but actually looking at what is it we need to do to make the changes and reflect on that to improve that rather than changing the content of it, just to clarify.
Okay. All right. Thank you for that. Anything else on that before we move on to Chief Exec's report? Over to you, Kate.
Thank you. So apologies for it being a verbal report this month, just to run through a few things. So I just want to reflect on the period over Christmas and New Year, where the whole of our economy came together to try and make sure that we had the best possible access to a whole range of services for our people across the Christmas and New Year period. As ever, Christmas is a very difficult time operationally, and just before Christmas we were reminded by the Secretary of State for Health and the Secretary of State for Social Care that of all the systems in the country, we were probably the most challenged in terms of emergency access. So the Christmas and the New Year period, with 2 bouts of industrial actions, we fared reasonably well in it, but that is to say that it is in the context of a difficult winter, and I'll come back to that later. But I just wanted to thank everybody for their flexibility around making sure that we got as many people home as swiftly as possible pre-Christmas, and that we kept discharges going all the way through the Christmas and the New Year period. So I'll come back to that again when I update on the winter paper later on. I've also received an email from Francis Tippett thanking us for the approach that we as a board have been taking to personalised care, and that it remains something that marks us out as a system that really does want to make sure that people receive the care they want to receive, and that we're planning for it in a structured and systematic way. So again, I just thought it was something that would be helpful for us to share in the board, particularly as we look into 24-25 planning, that we need to make sure that place is still very much at the heart of what
Just
we
remind everybody who Francis is.
So Francis is the regional lead for personalised care, and is supported by Juliet in a part of a regional role and a number of other colleagues. And then I can't read my own writing. I've made contact with a gentleman called Damon Baker. I don't know whether people know Damon. He works for Cornwall Community Foundation. His background is as an investment banker from Los Angeles, I believe, works in London, lives in Cornwall, and he's one of the non-execs on the Community Foundation board. And he chairs the Impact Committee. So as investments are made across Cornwall, he's looking at the economic evaluation of the impact. So I'm going to ask Damon to meet with Simon, our CFO, and Chris, our CMO, so that we're aligning the impact of evidence-based interventions at place along with the financial return on investment, so that we can build that into our evidence-based investment strategy for next year and future years. And then my final point was really to thank the people in who work in the Integrated Care Board. So we are just about to agree our phase 2 restructuring proposals, and they'll go out to consultation hopefully in the week beginning the 22nd of January. For our people in the ICB, this has been a really long and bumpy process to get to this point. So they've been waiting for this consultation document for nearly 2 years now. Because there was a people promise that was put in place when the ICBs were put in place. So phase 2 will be followed by a phase 3 later on in 2024. But I just want to thank all of our staff who are continuing to do their best in difficult times, and we as a board will make sure that we get through the restructuring as swiftly as possible. And that was it for me in terms of updates.
Any questions for Kate? Okay, let's move on to the integrated performance report. So Kate Maynard's not with us today, and as I explained, Simon is stuck somewhere with an electric car. So Susan Bracefield is...
We can say why she's in.
Yeah,
So Susan's daughter had her thyroid operation yesterday, so she's with her in London, and it went well, so that's good. She'll be back with us soon.
So in terms of structuring the discussion, Kate, I'm afraid it's going to fall to you to have to help us lead through here, so I'll hand over to you.
Okay, thank you. So you have in front of you the integrated performance report for the last period, and I think it's November data that's in it, so it's still out of date, but we're trying to get our data in line with our board reporting. Overall, our soft segmentation hasn't changed. We're still in system oversight framework level 3, and working hard as a system to take the actions that move us into level 2, and to give confidence to our national teams that we have got a grip on everything that we're doing in Cornwall and the Isles of Scilly. We are failing to meet our constitutional standards, and that's really clear from the data all the way through the report. But that said, we are making significant progress around our elective waiting list recovery, and I think we're up to around 62% referral to treatment, the national standard being 92%. So we just need to remember that we are making progress, but we have more to do. The urgent and emergency care performance is something that for us as a system should continuously be on our minds, because we know that we sit in the lowest quartile of performance in the country, and at times in terms of access to an ambulance through the CAP-MEAN response, we are one of the worst performers in the country. I won't go into the winter plan because that's later on in the agenda. I'll pick that up when we go through that. Our finance performance has, we've declared that we will break even, but that is now complicated by the latest rounds of strikes, and there is a lack of clarity around whether the December and January strike costs will be met by central government. So we are just going to have discussions around how we recut our plans, but at the moment it looks unlikely that we'll be able to hold to a forecast outturn that allows us to break even, and we may need to post a deficit for the cost of the strikes. But that's something that all ICBs are having discussions with their partners across the country. We can seem to see some pressures from the ICB budget around prescribing, but actions are in place to manage this down, and we are still very fortunate that our elective recovery fund and the work that RCHT and CFT are doing to mean that we can income generate into the county through doing more work than we planned to do, which allows us to have some flexibility in our budgets. So my reflections would be that as a system we're still failing to meet our constitutional targets, but the plans that our providers have put in place to show recovery during 23-24 are in large part being met. We will have further stretching targets as we go into 24-25, and I don't think there's anything I need to bring to the board's attention over and above the pressures that sit within the UEC pathway and that continue to be challenging for our economy.
Okay. So let's try and structure the discussion on the basis of what's in the agenda, which is performance, quality, workforce, finance, and then elective care deep dive. So let's just start with performance. You've got the papers in front of you. You've heard Kate's sort of overall summary. Based on the performance numbers in here, what would we like to add? So maybe I could sort of just maybe look to Steve maybe to help us here in terms of your perspective on this from the provider partner perspective. That'd be really helpful.
Yeah, absolutely. I'd echo Kate's comments about how the system has worked together through the Christmas and New Year period. It's been really helpful to see, and I think that gives us some further optimism to support the rapid progression of the winter plans. And I think all providers, I think, around the board table would I think have a similar view about the increasing way in which our system is working together and putting aside organisational barriers and finding different ways to work. If I could just really briefly comment from a CFT perspective, really just to say thank you for the Bodmin same-day emergency care implementation. So this week we've got a really important strategic implementation led by Cornwall Partnerships NHS Foundation Trust, which will provide more local access to emergency care and support the avoidance of frailty admissions. So really positive steps forward, really significant, and there's a range of other actions that are already set out in the winter plan, which is very positive to see. As Kate has already said, the ambulance handover performance must improve rapidly, and must improve urgently. And all of our H2 winter plan is designed to enable that to happen. It is not yet happening at the speed that we would want it to happen. And the steps such as the Bodmin same-day emergency centre, the actions within RCHT and across a wider system, we need to find every opportunity to accelerate. The other area of performance concern, I guess, particularly is the speed at which we're improving our elective waiting times. And a number of specialties have proceeded very, very well and are approaching the 52 week position, which will be a year ahead of where we need it to be. But as we all know, orthopaedics is the significant area of concern. So significant amount of focus in enabling that to progress. Recognising that orthopaedic risk, the increasing elective activity delivery, I think, is really significant. and that's recognised and referenced in the report as well. I think that's a good indicator of an increasingly productive elective service overall. But again, that needs to continue to improve into next year if we're to succeed in the expectations for next year.
Okay, I'm going to go around and ask a few key players. So Debbie, I'm sure you'd like to pick up on what Steve was saying there. So over to you.
First of all, thank you, Steve, for the recognition. And we had our regional chief executives meeting this morning, and our regional director, Elizabeth O'Marney, was actually encouraging colleagues to start the new year with some reflections of things that actually we're proud of or that have gone well, because we know we have faced quite significant challenges. And my reflection, because this is now, believe it or not, my third winter in Cornwall, the time absolutely flies. But despite the challenges, the strength of the relationships and the opportunities to problem solve and get things sorted much more quickly in a non-organisationally defensive way is actually much more palpable this year. And we're able to have some of those difficult and challenging conversations in the context of doing the right thing for patients rather than our organisations, and I think that's increasingly being recognised. I went to see our new frailty same-day emergency care unit, and John, if you would indulge me for a moment, the opportunity to do that in part started with the space being freed up because of the investment through the targeted investment fund in the community diagnostics centre on that site. So this is yet another demonstration of the system working, that by collaborating and working together, we're actually getting more out of our community assets for local people. And the same day emergency care is not a walk-in, so I just need to stress, because we're in public session, we still have our minor injuries offer on the Bodmin site. This is for what we call GP expected referrals, for referrals out of urgent community response, and most importantly, the ambulance service. So it provides an alternative for people with a low acuity score but a high frailty score to come and have an assessment, maybe some interventions by way of rehydration or antibiotics, and then back home with the appropriate level of support. And although it's a small beginning, it was just really positive to see the excitement and energy of the acute GPs, the nurses and the therapists that are all working. And actually they received their first referral while I was there, just before it opened. So it's inevitably going to have some constrained capacity, and inevitably we don't want to move an ambulance queue from one place to the other, so we need to ensure that we work really appropriately on our dynamic risk assessment. But linking that then with the CATU does mean that we've got an improved offer, and importantly an improved offer for mid and northeast Cornwall, because this will take pressure off of ambulances going to both Treliske and to Derriford. So it is a phased implementation. It won't be all bells and whistles and extended hours from day one, but it's up and running, and I'm absolutely delighted for the support. Could I also just mention, while I've got the mic, that virtual wards, we have put in place the increased capacity to now 212 spaces on the virtual ward in December. And although inevitably, because we're monitored on occupancy rates, the occupancy rate takes a dip because we've increased the capacity, we're now back up to 74% yesterday. And we've increased the run rate of starts from 4 a day to an average of 9 a day. And at its peak last week, when we were under significant pressure, I saw 12 new starts in a day. And when you think that that's dispersed across the community, that's actually a significant workload. And linked to that, we now have our clinical leads for the virtual wards now leading some of the acute respiratory infection hubs, which we're supporting primary care with. And again, the value of that is that they can immediately put somebody onto a virtual ward should that be the indicated outcome. So I know I've been slightly verbose, John, and I
No, that's fine.
apologise, but I think I'm trying to demonstrate that through the collaboration and convening power of the ICB, we really are beginning to see much better place-based coordinated care and alternatives to hospital care for our communities.
Thank you. And we'll, as the day goes on, and I'm sure as the month goes on, that focus also on place-based activities is going to just enhance. I'd like to just bring in 2 or 3 other people, and in no particular order. But Ali, would you be kind enough? I mean, we've got a session later on to do with the winter plan, and I don't want to sort of do it twice. But is there anything responding to the performance that you'd like to raise at this point?
Thanks, Chair. I think just to reflect that it's been a really, really busy, challenging period across our system. I think people have worked really well collaboratively across all agencies. And I think I just wanted to mention our social care providers as well. You know, there have absolutely been social care providers that have been taking admissions into their care homes during the whole period of Christmas and New Year, including the weekends, including the bank holidays. And I think that's a real credit to our partnership arrangements. We've had some challenges, and I won't go into those here because it's not appropriate. Yeah. But I just want to reflect on the strengths of our market and that relationship that we have with some of our providers, which I think is really, really positive. And I think that, you know, we talked about numbers, and we have seen the numbers of complex discharges for our residents from hospital systems higher than I've ever seen them since I've been in Cornwall. There was one day earlier this week where we achieved 52 complex discharges across our system, and it's been over 25 average throughout the whole period, but actually it's been in the 30s and 40s quite often as well. So I think that's a real tribute to the collaboration at place and the ITOCs. And that kind of coordination. And I think just to mention and plug, I suppose, that our provider collaborative has gone live this week as well, with reablement teams all coming together to optimise their capacity. And certainly they've gone live on Monday in RCHT. And I think, you know, we had Intermediate Care Board on Tuesday. We were already hearing some really, really good progress being made.
Excellent. Yeah, the reason why I was very keen to bring you in is I'd heard that too, and I just wanted to sort of celebrate that kind of thing. So shall I move on to some of our GP colleagues as well? And
just mention the discussion we had with Helen Waitley, with the Minister. So one of the things, we were asked what we thought might make a difference for social care. And the NHS has received a letter that's signed by all of the professional leads for NHS services that effectively asks people to do what is right at a moment in time when services are stretched. But that hasn't been offered to our third sector, our social care providers. So both through the Secretary of State meeting that the region had and our meeting with Minister Waitley, we've asked whether that same letter could come out to our social care providers, and they're picking it up with the CQC, because we need people to make decisions that are based on the risk in front of us and not be judged against them at a later point in time. So I'm hopeful that we might see some more structured national support.
Very good, thank you. Can I bring in Stuart? Can I offer you the opportunity to add to the discussion?
Yeah, I mean, obviously, my sort of main update would be around the kind of winter plans, but in terms of obviously pressure and the kind of Christmas period in general practice, obviously, you know, it's great to hear about all the initiatives to reduce the amount of frailty in the hospital. And obviously we all welcome those. I think there was a bit of feedback from our hospital colleagues and ambulance colleagues that perhaps some of the pathways in terms of admitting frail patients were not always being adhered to in the community, and so there's been some work led by Rob recently on bringing together GP leaders to make sure that that's been addressed. You know, obviously, but important to bear in mind that where there's less frailty in the hospital, that means more frailty in the community. So my colleagues are concerned about some of the recruitment and staffing issues in our district nursing teams, which is in turn putting pressure on general practice by them not being able to fulfil some of their obligations around routine blood monitoring, etc. So obviously that's of concern. I mean, I think we're going to come more on to the kind of winter pressure plans, etc. So perhaps I won't go into detail that at this point, but suffice to say that there's been a really impressive effort in mobilising the acute general practice winter hubs across the county, 50 staff recruited. And I think really underpinning that is the strength of the collaborative board. So Cornwall now genuinely has a place to go to for a collaborative, joined up opinion for matters of general practice. And I think without the collaborative board functioning really quite effectively, there's no way we would have been able to get the winter pressures, the winter clinics up and running. So, I think that is a good news story. But really important to remember that where there's less frailty in the hospital, that means more frailty in the community and more complexity. And obviously that puts pressures on general practice, which in a lot of places is, already creaking at the seams.
Do you want to respond to some of that?
Yeah, so I'm really grateful for Stuart's update from primary care. And of course, as the community provider, we sit in that interface, really, don't we, between secondary care communities and primary care. And it is fair to say, Stuart, that while we've been dealing with quite considerable urgent and emergency care pressures, there are times when the routine work has to be reprioritised for the urgent work. But all of the teams have got a very clear protocol for ensuring that those that have the greatest need are the ones that are seen on the day, particularly the urgent care on the day, and supporting people home. We have got a shortage of district nurses, and I know last month we spoke at some length actually about our workforce numbers and the recruitment increases in some areas. And although we have been more successful in the last year than in previous years of attracting new district nurses, and actually we've increased the placement numbers so that we can grow more of our own, it is still a specialty that is hard to recruit, particularly in some of our really rural areas. So if you look at areas like Callington, for example, we've got 2/3 of our band 5 vacancies vacant, band 5 vacants, because of the challenges of working across a very rural patch, and people prefer to be able to work in a more sort of urban town setting, and that becomes even more acute in the winter. And I know it's obvious, but with dark lanes, stormy weather, and so on and so forth. So I think it's really important that we also give a shout out and value the work that the district nurses are doing, because we actually want to continue with our efforts to grow more and do more. And it's working at PCN level where we're going to be able to overcome, Stuart, some of these local challenges, because it's not the case in all areas that we've got challenges, but it is quite acute in some PCN areas.
In others, I just want to alert Patrick, I'll be asking you in a second then based on that, particularly given the fact that we're about to move into a more granular discussion next month and the month after in terms of planning for next year and resources as to what's happening with productivity from a workforce perspective and resourcing and that kind of thing. But can I just bring in Chris from your perspective? What is your seat telling us?
It's just a combination of there's a lot more collaboration happening. There's been a lot more understanding, I think, of everybody's role across the system, other than just in their domains. So, such for example, primary care really stepping up to run and support these additional clinics, with the purpose of keeping frailty away from the front door. So there's lots of green shoots, but I'll emphasize what Steve said. There's still a lot of work to be done, because there still is right now too much frailty going to the front door of ED, and RCHT is incredibly busy, and so there's a lot of work to manage. But I think aspects of our winter plans, such as the frailty SDEC, are only just coming on board.
Maybe we can pick that up in
Yeah.
a discussion we'll have on the winter plan. Yeah.
A brief comment, if I could, John. It follows on from one or two of the comments that have been made. The performance report has a section on ambulance conveyances and identifies that during December there were fewer than 100 ambulance conveyances per day on average, and those attendances have been lower than expected. That is correct. On average, numbers have been lower than 100 per day. The numbers have been increasing. If you look at the position in October, it was an average of 81 a day. November, an average of 84 a day. December, an average of 87 a day. In January, an average of 92 a day. And I'm mindful of the challenges that we've seen in terms of the number of ambulances that have been waiting. And to an extent, we can map that on the days where ambulances aren't being held. There is a strong correlation with those days where conveyances are over 100 ambulances. So I wouldn't want us to misunderstand or kind of draw a conclusion necessarily from the information in the performance reports that do show ambulance attendances have been below 100. They have been, but that would be significantly impacted by the number of ambulances being held. And the trend through October, November, December and January, as our ambulance handover times have reduced, has been an increasing number of ambulances arriving.
Yeah.
So we're all working together to have the community mechanisms, to have alternatives to conveyancing, and that is absolutely, in my view, the solution to these challenges. But we do have a long way to go on this journey.
Thank you. And later on, I think it's important when we get to the winter plan to understand there's the data and then there's the nuances of understanding around it, which we'll unpack in a second. But I just want to bring in a couple of other people. I mean, Andy, from your seat, anything you want to add?
I think Stuart's probably covered off my primary care brief quite well. So I might take a small divergence, but only for 30 seconds, Chair. So speaking as a board member, I suppose my anxieties about what I see in the performance report are manifold. I share the Chief Executive's anxiety about non-elective care. I probably would just highlight some of the quality stuff. And particularly we're looking at some of the infection stuff. So the increase in the Clostridium difficile rate is a concern, and that probably is a sign of a community under pressure, an increasingly frail and older community, but also a system under pressure. So there are a lot of good news stories here, but there are still some things that give me ongoing anxiety, and I wouldn't want to forget some of the quality aspects.
Nick.
Yeah, so thank you, Chair. I mean, I think, the stories say, the culture and collaboration which the system is showing to deal with stuff is only going to make things better, and loads of great stories within that. And, my community pharmacy role, we would see ourselves as supporting primary care and the rider system within that. There are two just on the sort of overarching principles. I think Kate's articulated really well about the strike action and also about the positive financial outcome being on some of the extra work that's been done. So the question, obviously, I know this isn't unique to us, but 42 ICBs are going into that, the financial outturn part of that. And then also, is the modelling done if that extra work stops because of the strike action? So the two things are kind of linked in and played into that a lot of our financial performance and, potentially the extra work, but that assumingly will decrease. And then obviously, within that prescribing budget as well, I think there's lots of things you're doing, but again, the recognition that a lot of that is driven by national things that are drug things moving that are outside of control. And those are sort of two overarching things. I think almost as a system, I don't want that to underplay some of our great work that we're doing with collaboration, which almost feels outside of some of our control within there. And just any thoughts on how that looks and how that offsets as a system?
So just before, thank you for that. So just before I move on to getting a contribution from Emma, as we're getting, and Rachel, as we get towards the back end of this year, obviously the quality angle of this is got to be driven through. And then the extra pressures that the industrial action are putting on us in terms of the break even is, I wouldn't want us to lose the fact that we've got to do both.
Exactly.
And the reason for that is obviously doing the right thing for our residents, but also just from the financial perspective, my understanding is if we break even this year, we have our historic debt written off, is that right? So there are all sorts of reasons for doing the extra mile in this last few months. Do you want to respond to that before I bring other people in?
Yeah, if it's okay, just briefly, we can absolutely address that. So I can give a position from a Royal Common Hospital Trust perspective. There are additional costs in CFT, but the significant proportion of the costs from a system perspective fall within RCHT. So the direct financial cost of the 3 days of industrial action in December and our assessment of the 6 days cost in January is a financial deficit of 1.7 million. And the lost income is 1 million, so a net cost of 2.7 million pounds, which has a direct financial deterioration on the system's forecast. There is a mandate for junior doctor industrial action through till the end of February, so it is conceivable that there could be further industrial action. But currently, the headline impact would be 2.7 million pounds plus the smaller financial impact of Cornwall Partnerships NHS Foundation.
Just before I bring Rachel in, could you respond to this and also my comment about having the need to do both quality and in-year
If I
finances?
just bring everybody's eyes to page 18 of the paper, page 23 of the whole pack, that goes through the key risks for each part of our organisation. So the ICB prescribing individual packages of care in mental health and community health service, continuing health services, non-ERF related activity, funding allocations that are already assumed in people's plans but may not have a source of funding for them, delivery of efficiency plans and winter pressures. And then for RCHT, delivery of efficiencies, service pressures with capacity and inflation, and the potential future costs of industrial action. And CFT, the delivery of efficiencies and service pressures. And in the table below, it shows some of the gross movements in risk across our system. But in overall terms, the gross risk has reduced from 42 million to just under 33 million. Now, Steve, there are industrial action costs in here of 2.84 million for RCHT. I'm not sure whether they are the costs that you've just described or whether they are pre the latest round of industrial action.
So the H2 plan the system submitted, we were directed by NHS England to explicitly assume there was no industrial action and to submit our financial plans, our operational plans, our elective recovery plans on the basis of no industrial action. So I believe they exclude that. The figures I've just covered, the 1.7 million pounds of cost and the lost 1 million of income, net 2.7, are a detriment to the H2 financial position, and I think that's the position in every other system across the country, where all systems are grappling with this position.
Okay.
Absolutely, I wasn't suggesting that that's not the case. So one of the things we are going to have to work out is strategically, if we do want to have our historic deficit written off. So if there is going to be no additional national funding, we're all going to ask for it, because to try and pull that amount of money in the period of time we've got is nothing short of Herculean.
Yeah.
But we will be posting the deficit and also looking at how we can put efficiencies in place across the economy.
Thank you so much, Kate. Rachel.
A general point, really, I think, just in the interest of covering the whole of the population of Cornwall, the performance report invariably refers to RCHT performance, so it's just a question and to the author of the report around how a summary around both Plymouth Hospital Trust and perhaps North Devon is incorporated at a high level. So there are bits in there, but it's not clear. And the majority is looking at RCHT. So as the board member, that's what we're having a look at. So there's a question around how that is sort of responded to. And I think the primary care element of the report last time was developed somewhat, and we all said how helpful that was, but it's dropped out. So I think there was just another ask, because gives the ability to look at the sort of prevention and management of conditions as part of reporting as well. So I welcome that return. And then there was just one general point about finance, which is I noted that there was a surplus relating to dental care that's been recognised as a part of the system. I don't know, you're shaking your head, Kate, so that might have moved on since the report was written, but I guess does that mean a real investment in that area?
So I'll go backwards through. So at the last board, I don't know whether you were here, Rachel, in order to hit our H2 plan, we were asked to consider the worst case scenario. So our dental underspend is included in our control total for break even, as is our restructuring cost. So everything that we can put into breaking even this year has gone in, which is why I'm saying it will be Herculean effort to buy off the impact of industrial action. The Plymouth data is in here, but it's not pulled out well. So we presented the October data to the Overview and Scrutiny Committee, who asked the same question. At aggregate level, Plymouth is included in this, but we need to be able to distinguish between the two different activity flows because the impact is differential on both hospitals. And the primary care, I'll pick up with James Foss about making sure that goes back in again. While I've got the mic, so to speak, I do also want to pick up risk and harm, which is coming through via our regional colleagues around UEC performance. The CQC are becoming increasingly interested in how we're managing harm through pathways into and out of hospitals. So we had the foresight as an ICB to put in place a mortality and morbidity committee, not just a mortality committee. So Chris and Alistair Grant from RCHT looking at the impacts of potential harm through waiting. The coroner has given us a second regulation 28 letter that arrived just before Christmas. Ali and I are meeting with the coroner because some of the evidence that was given in coroner's court we would like to talk through with him, but he is going to start joining the mortality and morbidity committees at RCHT. He's got an open invitation to attend and he's going to avail himself of that.
Okay, so I'm just conscious of time now. So, Patrick, I said I'd come back to you on the workforce thing. What do you want to add in terms of not just this year and the implications, but what this might mean for next year?
Yeah, thanks, Chair. If it's okay, I'll cover the workforce aspects of the IPR and then move into that. I think I wanted to start with thanking the board for their patience on the absence of workforce data in the IPR over previous months. We are working with colleagues in our regional team and trusts on developing a system-level workforce dashboard that will bring kind of core workforce data relating to the makeup of our health and care workforce, and increasingly be providing metrics that enable us to address some of the issues that we dealt with at length before Christmas relating to size, workforce productivity, capacity, and so that reporting is the direction of travel in terms of what we'll be bringing here. Couple of comments around, we've touched on this in previous conversations. So the maturity of workforce data, we're at step one of what I would estimate to be a 20-step journey on bringing together integrated workforce data across health and care. That reflects the fact that our workforce data is held at organisational level. We haven't integrated that at system level. And in our NHS organisations, the data will have a maturity that isn't the case in primary care, which is made up of lots of separate employers. The independent care sector, similar scenario. So our ability to bring health and care workforce data at this level is the job in hand. Nonetheless, what I did want to highlight in the report in Appendix B is starting to include the type of data that we would want to be able to report into this board, and it starts with the NHS organisations, but you'll see in the report that will typically pick up characteristics, so our inclusion characteristics, age and sex profile of our workforce, absence, retention, are the types of figures that we may be able to monitor over time to see how are the characteristics of our workforce changing, how are we doing on retaining, some of those capacity measures that we would want to be really clear that we're increasing our performance on those levels. And the other bit then will be the more performance related parts relating to where we'll have specific aims, reduction in agency usage, and the impact of that on our overall system performance. So I think that's the key part I wanted to update. Moving into next year, Chair, given your specific question, a couple of principles around that as we're starting to think about the 24-25 planning. So firstly,
the integration of that is going to be really important. So in the planning, we would need to bring together activity, finance and workforce expectations as part of setting the agenda for next year. And it will be that triangulation of those measures that will need to be reflected in future iterations of the IPR that we bring here. And we know we're going into a challenging planning round in that regard. The second element in that planning part is about how new models of care are reflected in the way that we describe our workforce makeup going into 24-25. And we've had previous conversations about the clinical priorities that would be looking to develop new models of care around. So from a workforce perspective, that will give us a different view, end-to-end view of the total workforce that might work in, for example, the cardiology pathway from place into acute, and then we'd be modelling our workforce data in a different way. So a couple of indications of direction of travel as well, Chair.
Okay, thank you. Steve?
I wasn't sure where to raise this. I don't know if it was appropriate in this section or not, but it's a question for us about where in the performance report do we consider things like the 12,000 additional primary care appointments. There's a really significant investment which should directly contribute to reducing the potential avoidable conveyances. And I don't know whether we're capturing that and reviewing it through workforce growth, although there isn't a primary care workforce section, or whether it sits elsewhere. So I wasn't sure what our mechanism is to see that progress.
I think it's an explicit part of the winter plan. So we'll need to do a post-winter wash-up and work out whether the investment we've made in the schemes we've invested in gave us the return we wanted. That's where I would want it to sit before we determine whether we carry on with that model or use the resource for something else.
Thank you, Stuart.
So just a couple of comments on workforce data. The CIC, Kino Health, does have quite sophisticated primary care workforce data. So I think it would be good to liaise with them to bring that primary care data, alongside this as part of the system. Equally, just further to the discussion that we were having in the last section, it is really, really important for the frailty agenda and the place-based agenda that we have good quality data around our community teams and the workforce restraints there. There's a significant risk, I think, to the frailty agenda because of the fragility of those teams. And then also just to reassure Steve and colleagues that we are collecting data on around the extra primary care hubs and indeed the knock-on, hopefully, on frailty reviews. Of course, always hard to prove cause and effect of one intervention onto people not getting admitted, but there is data collection at hand via Kerno CIC for those winter clinics.
Do you want to respond to that?
So I think one of the things we just need to reflect on, because I'm listening to this conversation start so into primary care and then into community services. One of the truths we've got is that RCHT is easier to performance manage and to look at because of the way the activity is codified. So we just need to be really careful. We're giving the same granular detail everywhere else. So Steve's point's well made, but we do need to get into how all the bits of our system come together to give us the aggregate response that gives a better deal for the people that we serve. So we'll pick that up and take it offline. I'm not sure it's necessarily just a workforce piece of work. I think it's a productivity and efficiency piece of work too. So we'll take that away and maybe we could bring something back to a future meeting for a deep dive.
Yeah, really basic point, Chair. So I know that in community pharmacy as a non-NHS managed sector, there's a workforce study that's done. I've just asked if that can be broken down regionally just to feed that in. I think as Pharmacy First is launched next month and community pharmacy in theory becomes more part of the NHS recovery plan and an integrated part of the system, then actually if we've got no capacity as a system, we need to know that. So I'll just feed that into wherever you guys say that needs to be fit in and see if I can get that broken down by region. But that's a short question.
Debbie?
I wanted to pick up on the workforce piece rather than the performance piece, if that's okay, Chair. Just to share that yesterday, Margaret and I had the privilege of being invited to the Truro and Penwith College Health and Engineering Satellite College on the Callywith site in Bodmin. So colleagues will have already heard me celebrate the fabulous health simulation training suites that we already enjoy in Truro. And now we have the same facility in Bodmin. So they've got an adult training room, a paediatric training room, and to my absolute delight, they actually now have a home care room with set up to look like someone's kitchen, someone's bedroom, someone's lounge area, even a wet room, so that they can begin to support those young people, because they're largely young people, because they're really looking at the T levels, entry level, as well as then more bespoke courses. But it's a really fantastic innovation for Cornwall that our colleges have picked up on some of our requirements as employers, and are now establishing themselves in a place where they can provide training for how to deliver care in someone's home. And Mary, they're really keen to, now they're up and running, because they had a sort of soft launch for the autumn term, but they're really keen to link in with care homes and the voluntary sector to see whether there's an opportunity to put in place some more bespoke training that really suits the needs of people providing that. So in our ambitions to support partnership working, I just wanted to celebrate that here, John, as part of growing our own in Cornwall.
Thank you. So, Ali?
Yeah, I was just going to say that's absolutely fantastic, and I set up a similar facility in my last role, so I'm really pleased to hear that coming through. And I just wanted to say if there's anything we can do to support getting that message out there to the market, and if there's anything we could be doing in partnership to develop that in other parts of Cornwall, I'd be really keen for us to look at that. But I also just wanted to ask, do you have all the kind of tech enabled kind of provision, and if not, are we able to support you with getting all that kind of tech enabled independent living kind of equipment into that facility?
So I don't know the answer.
Okay.
But I'm going to link you in on the basis
Perfect.
of what I saw yesterday. You're quite right. I don't think it certainly didn't have any of the virtual ward type facilities. It was more about the commodes and the walking aids and so on. But
Okay.
I guess in the first instance, I was just so thrilled to even see a simulation facility.
We've got a new tech strategic commissioner, Anthony Chard, so I'll
Brilliant.
put them in
You
touch.
link us-
Yeah,
we'll-
really good if we
we'll
can
link
get that up
together.
and running. Brilliant.
Thank you. Neil? Oh, sorry, Margaret, did you want to talk on this particular point?
Yes, just
Yes, sorry.
very, very
There we
quick
go.
one. Coming out of that, we're going to support students. We need placements, and we need placements across the community, not just in the NHS.
Okay.
So it would be useful to think about that. And we discussed that yesterday.
Thank you,
So-
Margaret. Thank you. Sorry, Neil.
Just to make a comment that listening to this discussion, the issue of collaboration gives me confidence that the sort of interdependency that we're now building across the system is something that people will hopefully become used to expecting, and will build confidence in each part of the system with each other. But I hear the word winter plan mentioned coterminous with this. I think it's really important to look forwards and see this as part of the way forward. And when I hear topics introduced by the phrase doing the right thing for people, this links with the values that we have as an ICB, and therefore it is important that we look at this as a longer term plan, and one that continues not just through winters. I'd also like to say that in terms of what you mentioned, Patrick, about the workforce and the links with what we might be terming clinical oversight groups providing assurance against clinical pathways, I think it's really important that those pathways are developed with terms of reference that link to the values of the ICB, and those values of personalised care, and the fact that people will often have more than one pathway. And that for me says that there's a little bit of a danger signal, because clinical pathways around disease have tended to produce super specialists in the workforce, and people who see people with a cardiovascular problem or a diabetic problem or a respiratory problem. And I would hope that those pathways will look to address the fact that we need people with generic skills who see people as people with the problems that they have, and the knowledge that those pathways and the assurance that they can provide will allow a generic workforce to work across with people in the right way, doing the right thing for people, rather than become super specialists.
Thank you for that. So I'm going to try and wrap up now, if I may. I'm conscious that with Simon not here, the elective care deep dive, I don't know how you want to deal with that, Kate, but I'll come back to that in a second, just before we do wrap up. But on the workforce bit and on clinical pathways, the reason why I want to just tease this out for next year as well is that if we're working on the assumption that there are questions still in terms of productivity across the system, relating back to March 2020, and our need to improve back to pre-COVID zone. If we work on the assumption there might be flat cash, even I can do the maths that with flat cash, it's going to have to be some reworking of how we have staffing investment, where and how, and that kind of thing. And we don't need to wait to the 1st of April for that, which is why I'm really keen for us to start to get our minds around from the February board meeting, quite what some of these implications actually are for our new financial year. And on the second point, which just building on something that Neil was talking about there, the clinical pathways, Kate, you and I have spoken a lot about the need to have this focus on new clinical pathways, place-based, and that kind of. Do you want to give colleagues some sharing of where that might be going over the next period?
So Chris and I have been talking about getting our programmes of care up and running. So at the end of our restructuring, we'll move to a commissioning structure that will have 6 programmes of care that will bring together an expert clinician, a commissioner who's able to work with clinical support and advice to pull together clinical reference groups that will feed into a portfolio board, for example, for long-term conditions or for mental health, learning disability and autism. The mental health programme board steps up later on this week, and when we'll be looking to establish the 3 clinical reference groups. Each of those clinical reference groups will be use the same methodology to examine how much resource we've got with money, people, facilities, places for delivery across a continuum, for example, cardiology, to put in place a target operating model that is around more people accessing care in or near their own homes, underpinned by personalisation and choice around treatment pathways, and that we would look to restructure the pathway so that we're doing more out of a hospital and more in communities, with then a mobilisation plan that puts that in place over the next 12 months. We've already got target operating models for diabetes, and we have target operating models for frailty. What we don't have is target operating models for respiratory or for cardiology, so they will be developed over the coming weeks using national evidence. The whole emphasis around this, we've talked about left shifting, and I'd prefer not to do that, but to talk about place-based prevention, care, self-management and treatment if required. And one of the discussions we've started to have is, if we were going to be very ambitious, would we start looking at our preventative pathways around diet, exercise, decision making, so that people can make good choices, not smoking, because that's the etiology of quite a lot of our long-term conditions. And if we were going to save money by investing in an exercise programme, this is where working with Damon Baker would be so helpful, because we need to have a structured financial framework through which we can do an impact assessment for in-year return on investment and over years returns on investment. So that's the methodology that we're enabling to put in place. And one of the things that's right at the front of my mind, and I'm not a diabetic doctor or nurse, if I was, it would be more than at the front of my mind, was a NICE tag, technical advice guidance, was published in November last year for basically an artificial pancreas, hybrid closed loop technology. If you have type 1 diabetes and the control is poor, this allows you to manage your condition better but stop you getting the complications that come through poor diabetic control. I don't think we have a mechanism in this system at this point to invest the money we have to invest to get to the return for those people. And this pathway way of working means that for everything we will map ahead the things that are coming, so that the whole of our population, whether it's stopping people getting poorly or dealing with people who've got the consequences of fairly significant long-term diseases, we can make sure that everybody is dealt with well. And for that, we need to absolutely engage with Rachel's work around population health improvement, because that's where we'll be able to hopefully buy some of this disease impact off over future years. I think it's really ambitious, so we are going to need everybody's help, support and flexibility to get it up and
Final
running.
word, Chris, and we're going to move on.
It was just in that standardised a framework, and I've put my finger up. I think, as you then mentioned, Rachel, and population health. It's the importance is around the pathway needs to have an equity lens on it as well, and everything we do, and that has to be standardised across the pathways.
Thank you. So one of the things which we spoke about actually only this morning, we had a pre-conversation on a variety of things. And I'll just say to everybody, I've just realised Sanj, I've meant to send his apologies for this morning. He is joining us, but his boiler's blown up, and therefore I did think it was quite a priority for his family to actually get his heating sorted in this weather. So he is. But the reason why I said he did join us this morning, and as I said earlier on, we are talking about in our forward plan having for February our first high-level draft of what we might be thinking about for budgeting for 24-25. So I've asked Sanj to actually lead a conversation about, through FMP, before it gets to our February board meeting, what would those implications be? What are the high-level nuances that we actually want to put in place in terms of what we want to spend, how we're going to spend it, such that we can have a more granular, informed discussion at FMP before we get in to our February board meeting. And if I could just reach out, therefore, to Steve and Debbie with your organisational hats on as well as your board hats on, and actually just think about how, with Kate, you engage into a process through FMP such that when we have our February board meeting, it's a considered options. This is where we might be going, such that we could lead to a March board meeting where we actually start to firm it up. And it's highly likely to be, beyond our March board meeting, an end of March extraordinary board meeting, I fear, to actually sign off the budget. So if that's all right with everyone, I think it's important that we use those mechanisms to make sure what bounces into February's board meeting on finance and quality is well considered in advance.
Do you want to pick up the elective deep dive?
What I was going to say was, did we want to carry that forward into the discussion with the winter plan, or did you want to segregate the two?
So I think the elective deep dive is separate, isn't it? So notwithstanding the industrial action that I mean,
5 minutes on that.
Okay, so as a segue into the deep dive, I just want to draw people's attention to page 3 of the IPR, but 3 of 28 and 8 of 131, where there's a table around elective cancer and diagnostic soft performance, and at an aggregate level, it shows us how Cornwall and the Isles of Scilly is faring relative to other integrated care boards in terms of the tiering that we sit in. So for elective care and for cancer care, we're in the highest performing quartile. If you look at the cancer diagnostic standards, if we can manage to get diagnostics up to the level they need to be, particularly the faster diagnostics, then our cancer standards will start to return to the place we'd like them to be at, being compliant with the national expectations. Elective activity and total patients waiting more than 65 weeks is an interquartile range, but we go back to highest performing quartile for patients waiting more than 65 weeks and for cancer 62-day backlog. Where we are in the lowest performing quartile is in diagnostics, but there are plans in place for us to recover our diagnostic position and to be able to, through that, make sure that our elective recovery continues. The report that's in front of you does describe the growing waiting list that we're seeing across RCHT, and not waiting list, the growing numbers of people entering care across RCHT and UHP, with around 47,000 new entries in September 23. Compared with 21,000 in April 20 for RCHT, and 11,000 in Plymouth versus 6,000 in April 2020. So largely a doubling of the entries that are going onto the waiting list. We can also see that our RTT position, it was 80% in March 2020, the start of COVID, and it's now 61.07%. I think actually after this packet's just tipped into 62%, and that reflects what Steve's been describing in terms of the backlog pushing down from 78 weeks into 65 weeks and down into 52 weeks. We know that we have a specialty that causes us more concern because it's got larger volumes of people waiting in it, and that's orthopaedics. But we have a plan in place with RCHT to get orthopaedic waiters down to 65 weeks by the second quarter of 2024. the report goes into quite a lot of detail around what we're doing to support our providers in recovering elective services. So there's transforming of outpatients. So we've seen increasing waiting times and delays in follow-up, but there are digital mechanisms going in place to support outpatients, and both RCHT and UHP are taking special measures to get their outpatient waiters down. We're prioritising diagnostic services everywhere, and there's a very clear focus on early diagnosis and treatment of suspected cancers. We have started offering people choice at the point of referral, because we need to address the waiting list from both ends. Those that have been waiting for a long period of time, giving them choice to go to another provider if they're able to meet their care needs, but also at the point of referral, offering people alternative providers so that we're spreading the access to care across a number of providers, not just putting them all into one place. We're doing that from an equity lens, so that we're supporting people with travel costs, and if they're not confident whether they can take somebody with them. So I suppose my canter through the deep dive probably isn't as deep as it would be if we had one of our performance people doing it. But the summary is that we continue to increase our access to elective care. Waiting times are reducing. Harms on waiting lists that for specific pathways where we know that there is more likely to be harm incurred through delay, for example, with ophthalmology, through our quality meetings with RCHT and UHP, we're looking at the coefficients to make sure that we're protecting people whilst they're waiting. And we are in tier 2 of the elective recovery programme for elective care. And we just need to make sure we protect the resources that we've got through winter so that we can continue to improve access on our journey back to 92%. I don't know whether you want to add anything, Steve.
I think that captures the position really well. Just to observe that some of the performance metrics in the pack go back to June or July, so that there's a significant time lag, and I'm not sure if that might be because that's the time lag on the publication of the national comparator data. But if we look at for example, the elective activity value weighted elective activity growth versus target, that's showing for, I think that's June's data, an interquartile range, that the more recent performance shows a very significant achievement from a Royal Cornwall Hospital perspective on value-weighted activity performance or cost-weighted activity performance compared to target and compared to the base year in 1920 and the base year last year. So I am mindful of the time lag, and I think it would probably be helpful for us to find a way for that, even if it's just the RCHT data, to be brought more up to date, because it's certainly available at a much more recent time period than that.
Let's move to the recommendations, if we may. We've run slightly over in terms of time, but I hope you feel that was a valuable conversation on such an important issue at this moment, particularly as we're sort of halfway through the winter window. I think we've had a good discussion on the IPR report. In terms of being assured the exception reports are beginning to provide satisfactory assurance, etc., as recommendation 2, I'm happy to support that on the basis that it's using the words beginning to actually do these sorts of things. So on that basis, are you happy for the second recommendation to be supported? Yeah, thank you. And we note the ongoing development and integrated reporting. In fact, I'd also like to just have a shout out and say thank you to Kate and to your team. We've managed now to actually have an online real-time non-exec dashboard on one sheet of A4 for the big ticket items. So thank you for that, with trending and trajectories on there as well. So the non-execs, if you haven't received that great news, it's gone live in the last 36 hours. We'll link you up with that. Okay. Okay, so that's the IPR report. So a lot of that may have been an overlap with the winter plan, but when we come to the winter plan agenda item, which we are now, I just want to alert to everyone that having spoken to some of the key partners around the board table, we've chosen to withdraw the paper that was there. Okay, I think it's probably fair to say that one of the values of actually ensuring we stick to board papers on time is consideration and process to make sure it's done and considered. Papers might not always say what people want to have, so you can't end up with it always pleasing everybody, but we just need to make sure that papers are done on time and out. And it just felt, particularly for the board not to have considered it in advance and read it, and that it felt inappropriate to have the paper. That said, I still think it's so valuable to have an agenda item on the winter plan and to discuss it, because there are elements, particularly when I attended Sanj's, and I hope the heating's back on, by the way, Sanj. All right. When I attended your Finance and Performance Committee, there were some green shoots of good news on the winter plan. So I don't want to not talk about it, having just had an hour on the IPR, but I think a discussion would be of more value than actually relying on the paper. So everyone's happy with that? So Kate, if I could turn to you to introduce a discussion on the winter plan, please.
So the you may have some slides that came out as an earlier iteration, which are helpful. If not, I can circulate them later. And the paper that you will have on will have disappeared from admin control, but you may have already had access to it. It was a segment of the winter performance rather than a description of the totality of the pressures that we've got in our system this winter. So I just want to start off with, since our board in November, we have seen considerable pressure on all inpatient services, particularly through the acute access into the emergency department, and that's at RCHT and at UHP. Shortly before Christmas, systems who had poor access through the emergency pathway and who had ambulances holding outside emergency departments, chief execs from the provider organisations were brought together with the Secretary of State for Health to talk through what additional mechanisms they could take in order to be able to offload people from ambulances and into the physical infrastructure of hospitals. And the rationale for that was that we know that risk and harm occurs every time we have ambulances queuing, and that the overall risk evaluation nationally is that people are better, even if they're in corridor care or over occupancy on wards, than they are sitting in a queue outside a hospital. So chief execs from provider organisations were asked to go away and to evaluate what they could do with a dynamic risk assessment to manage more care inside their hospitals. The quid pro quo from that is, if we're asking acute trusts to take more people into their hospital, community and primary care and third sector organisations should be prepared to reach in and to pull people out as fast as possible, so that we dissipate risk throughout the system and don't just move our risk to another place hidden inside a hospital where you can't quite see it. So the run up into Christmas saw this happening within RCHT and UHP, and great flexibility from colleagues inside both organisations to make sure that they kept ambulance holds to an absolute minimum. Since then, we have had an escalation protocol issued to us that says that any ambulance holds up to 6 hours for our region all need to be declared through our regional oversight mechanisms, and that holds above 8 hours and 10 hours need to be avoided. I don't find this a difficult ask to be made of us. It's the right thing to do. But again, we come back to the polarisation at the top of the pyramid of care in Cornwall. Our acute services at RCHT and UHP is the place where the greatest the risk will be felt. So over the Christmas period, with our parts of our plan turned on, with parts to be turned on, which I'll come back to, we saw what I would describe as good winter performance, bearing in mind it's always a challenging time. And on the 2nd of January, we were the only system in the Southwest that didn't declare System Opal 4. That isn't to say it was a comfortable place for anybody to be, but it was a really good indication of that multiplicity of work that was taking place at different levels across the whole of Cornwall and the Isles of Scilly. And I do think it's something that we should be collectively proud of, and that's one green shoot that I would like to water, nurture, and make sure that we can grow it into more than one green shoot. Over the industrial action period, we've seen reasonably good performance, and we've seen our ambulance holds at a lower level than we have seen for a while. And I think our Cat 2 mean performance at one point last week was 22 minutes, which is amazing. We have seen it deteriorate subsequently to around an hour, and we are starting to see holds again, particularly overnight, going into the evening and in the early hours of the morning. And it isn't unusual to have 4 or 5 holds in our CHT first thing in the morning. We know from the distribution of some of those ambulances that it's when we have the Cat 3 healthcare practitioner referred patients that wait till the end of the day when the ambulance service isn't so busy with Cat 2s, and that's the time they pick up the Category 3s and take them into hospital. So the out of hour period for us, and I note Debbie, the frailty SDEC won't be operating extended hours. It is the out of hours issue that means that both for UHP and for Trelisk, ambulances go into a centralised point, sometimes taking people there who don't need to be in an acute hospital and for whom care could be treated somewhere else, for example, a routine investigation. So the way our plans are developing this winter, Ali and I have spoken to Helen Waitley, who was more interested in the discharge elements of our plans than the admission avoidance elements of our plans. And from the data that is observed nationally, so we need to make sure that our local data sets reflect what Secretaries of State see and is reflected in the Foundry data that NHS England collects, because that is what we are well measured against. They can see that we are discharging increasingly large numbers of people from hospitals on complex pathways, but we are struggling with our P0 discharges from hospital, and that's something that we need to understand as a system, and is probably more about our community services reaching into our acute hospitals than it is around pushing our acute hospitals even faster to be able to identify those people. So as an augmentation to our plan, I've spoken to Chris this week about how we would get to support the collaborative that's in place from a P1 perspective, but how we would get more community facing folk into both hospitals to be able to support the discharge pathway. The initiatives that we talked about at the last briefing for the winter plan, so the Care Coordination Hub that's run by Kerno CIC and provides the link between Kerno CIC's paramedics and the SWAST call stack. We've seen increasing numbers of people being pulled out of the call stack and dealt with locally across Cornwall and the Isles of Scilly. And there is a number in this pack somewhere that I've forgotten, but I think it's around 550 people have been taken out of the stack and dealt with by Kerno CIC. We're also seeing the Right Care car coming online. Now, it hasn't got point of care testing in it at the moment. It needs to have the point of care testing in, because particularly for care homes and for other more rural parts of Cornwall, it gives us the opportunity to not convey, but to be able to do the routine investigation in the place where the person is. And I am increasingly hopeful that with the Right Care car, with the home care line, and with Louisa Forbes, who works for CFT, her care home team reaching into care homes, we're only moving people to a hospital who require something that a place that's got co-location with level 3 critical care can give, and that acute care at home can be delivered in a care home in an environment that's familiar to people, so we don't cause differential impact through people feeling frightened by being moved somewhere else. The X-ray car goes live on the 29th of January. I am really worried about this because it was going live on the 1st of December, then the 30th of December, and now the 29th of January. So at some point it will go live at a point when we don't need it to be there. So we're going to have to make a decision as we go through January about whether we continue with that or not. 12,000 more primary care appointments are being put in place, and one of the things we might want to do with those primary care appointments, not wanting to prejudice an evaluation at the end of winter, is to seasonally reflect the things that we know those 12,000 appointments need to do, because for the winter it's the respiratory viruses, it's for people who've got chest pain, it's for the frail people who decompensate through the course of winter. But as we get into the summer, it might be for a different cohort of people that we might want to address it at. I'm only speaking off the top of my head, Stuart, so I haven't got any firm plans in my head about it. We've seen the support plans around treatment escalation plans go live. Important for Cornwall because 40% of people who die in Cornwall die in a hospital, and that's not their place of choice for death. So we do need to be very respectful that we can provide excellent palliation at home, but we need the model of care that's consistently available out of hours, particularly around pain relief, so that relatives feel confident that their loved ones can be managed in the place that they wish to be. The next generation CATUs and the ITOCs have gone live, and we're starting to see very rapid on-the-day management by our ITOCs of both step up and step down. And we've got additional capacity for P2 and P3 coming online in the mid of January, with the Dementia Hub going live in February 24. That's augmented by the Frailty Estate, which I have to say I am personally so excited about. And while we were talking, I emailed Caroline to say, can I come and have a look at it? Because with the population we're serving, having those places where people can go to that don't mean they need to go to an acute hospital, but they can go somewhere that meets their care and treatment needs, has to be part of our future development for services. The plan as it's articulated is rolling out. It is making some impact in terms of holding our position through a difficult time. There is still more we need to do because our level of ambulance holds is unacceptable, and we have had a 6-hour breach while we've been sat in the meeting today. We need to stop those breaches and do everything we can at this point to support UHP and RCHT in managing people through the hospitals and back to the places that they live in. I'm just going to make one last point and then I'll shut up. One of the queries I've got, and a crisis is always the bad time to examine a query because you should be spending your time managing the crisis. But no matter how quickly we move people out of an inpatient setting, the no criteria to reside doesn't shift. In fact, over recent weeks, it's got bigger. And 75–80% of our discharges from acute care go on managed pathways that the rest of the country don't see. So there's either something about our risk aversion in Cornwall to discharging people into their own homes, or we've got a super selected population, and I suspect it's probably a combination of the two. So we need to do some work as an economy without criticism to anybody that looks at how we get people out of hospital faster. And one of the things I've asked Chris to do is to set up a bit of a SWAT team that we can consistently, not now and then, consistently support our colleagues in inpatient services, both community and acute, around how we can take the risk on allowing people to return to their lives. And that's something that we'll continue to do over the course of winter. But I just want to thank everybody. I think there's been an amazing effort to do the right thing by our people. And we are starting to see signs of improvement. But we also know there's still a lot of risk being held in our inpatient settings.
Thank you. So I'm actually going to go to Neil first. I'll tell you the reason why I'm going to go to Neil is that, Neil, you chaired a recent one of our ICB integrated care area committees. Would you like to add some thoughts?
I think I said some of this before, but I do think it's really important that there is a recognition across the system that the work going on at Place aspires to become business as usual rather than just something that is turned on and off in the winter. As I think using the phrase "it's doing the right thing for people" is definitely underpins everything that we're doing. And my plea is that people working in areas of development within both the ICB and across the system remember that there's work that's, I suppose, real and ongoing and maybe described as operational, that's informing the needs, and that is being measured by people at Place all the time. And the opportunities that exist at Place to work with partners like the voluntary sector and across primary and community care is something that we just can't miss now. We've got to keep working together. And that very much came across in the ICA meetings, and action points were taken to ensure that we join up when we're talking about clinical prioritisation or clinical reference groups, that these link with Place, and particularly
linked with people with lived experience, so that we include people who are struggling with the issues that are being described as part of the reference groups, and that we build on the knowledge that they provide. I think it's just about making sure that in planning, we don't miss the impact that can happen at place. If we're going to be moving resources closer to people's homes, working with neighbourhood teams and working with PCNs, we need to ensure that planning streams across the system absolutely always reflect what the art of the possible is at place.
So, Martin was next.
Just to follow on really, John, if you don't mind. I mean, one thing that I was interested yesterday in the discussion where we did discuss the winter plan, and of course, you know, I was slightly guilty, as we are here probably, of coming in straight with what's the effect on the ambulance waits. But I was reminded that actually people on the ground were reporting back that because we have put quite a lot of capacity in various places, and we do so in primary care and other things, there's a bit of a sort of decompression across the piece, if you like, which was felt to be providing better care, you know, at the primary care level, you know, a vast majority of people in Cornwall who may not end up at the sort of pinnacle of the ambulance rates. Hopefully those things, you know, join up to reduce the sort of people at the pinnacle coming into Trellis, but we oughtn't to forget that actually as well, you know, the programme is perhaps, you know, providing a sort of broader benefit, you know, across the people of Cornwall, I would say.
Thank you, Martin. And that's exactly why I started with Martin, actually, rather than starting as you possibly could have expected with RCHT. So, Chris, you wanted to say?
Yeah, just to add to Kate's point, I think another key point of our winter plan has been the comms from a public facing but a workforce facing, and the reason for that is because we're already seeing, for example, Louisa Forbes's team, she's getting double the amount of referrals. So it's just that education of the workforce that actually these programs are there and available, and then that helps with the risk appetite, which is really important from a primary care perspective when they're managing frailty in the community, which is the fundamental plan. And the other element of that is the clinicians reminding everyone to stick to the plan. Even though if Susan was here, she would be reminding us it's an iterative plan, so it is there to be reflected on, and we can adjust as we see fit as we go through the winter.
Any other comments, Debbie?
It would be remiss of me not to mention mental health, John. One of the key elements of our winter plan was also to ensure that we'd got appropriate resources and support in place to support mental health crisis over the winter. We have regrettably seen an uptick in mental health crises going to A&E, and we've seen a slight uptick in the 12-hour breaches for mental health. We understand that there's a ministerial focus now on mental health breaches in emergency departments, and there's an absolute national focus on bringing down, and it gives me no pride to use this data, bringing down 72-hour breaches in A&E departments waiting for onward care, to bring the 72 down to 48, down to 24, down to 12. Now, we're in a fortunate position that we haven't hit some of those higher levels, but nevertheless, there are times when we exceed the 12 hours. So in December, we had 6 greater than 12-hour breaches. That said, and you will have heard me say this before, the opening of the second Section 136 suite in the county has made a phenomenal difference to the reduction in 136s going to RCHT. And in the last month, only one formal 136 was taken there, and that person needed physical health assessment as well as mental health assessment. So there is now a regional protocol for escalation that between us will be working through to ensure that we are absolutely cited at the earliest possible opportunity. It's quite a complex process, colleagues, to move someone from an A&E department to a mental health bed that can require formal admission under the Mental Health Act. So it requires liaison across a number of different services, but it is nevertheless a quality improvement that we're all committed to making.
Stuart?
Thanks, John. Just very quickly, just on a couple of points that have already been raised. I mean, I think really important to remember that the primary care winter clinics are very much with an eye on general practice transformation in line with the national direction of travel underpinned by the Fuller report. And then just quickly on to reiterate the purpose of those clinics. Those clinics are there to see the episodic acute care, the people who do not need continuity, and therefore freeing up our list holding GPs to do more of the kind of frailty and complexity work. And just picking up on Kate's kind of the kind of move through the seasons and what might happen. So today in St Austell, because of that clinic, that's freed up an extra clinician within our GP practice to do 6 home visits of our frail elderly population. So a more responsive, proactive attempts to care plan and keep people out of hospital. And then the plans as we move into the spring will be for group clinics for our COPD patients with respiratory, with a high incidence of respiratory attendance to ED and general practice. And there's evidence base around that kind of peer support network, keeping people out of emergency departments and GP practice. So they're there for the acute episodic care, but it's the GPs who will be doing the kind of admission avoidance stuff, and that's the design of the system.
Thank you. So I'm really grateful for the work of system partners across the system to take the kind of actions that have been just described. And if I can acknowledge the S136 suite, that is an extraordinarily important development in terms of enabling right care in the right place and reducing pressure on the emergency department. So thank you for that. However, our collective actions, John, are not delivering at the necessary pace or scale or impact, and that is our collective actions across the whole system, including Royal Cornwall Hospitals, NHS Trust. As Kate has said, just as an example, we have had an ambulance waiting over 6 hours outside of the emergency department today, where we have 9 ambulances holding currently. That is not untypical. If I refer back just briefly to the integrated performance report, there's a table in there which shows by month the number of ambulance hours lost being held outside of the emergency department. It is not an acceptable position, and I think my challenge to all of us is what further extraordinary risk actions can we take to accelerate the plans that we have and to enable more risk to be taken in primary care, more risk to be taken in community care, and more risk taken elsewhere, so that we can be assured that we are moving at the fastest possible pace to accelerate the work that's underway. I also have a question for Sanj as to whether there's any further information which would be useful to the ICB committee to enable the assurance functions to be undertaken. I'm mindful of the conversation we had a little bit earlier on about the wealth of Royal Cornwall Hospital performance information and the lack of equivalent detail of information in other parts of the system. And I think that feels to me an opportunity for us to further progress so that we can have the assurance, which I think will build the confidence and trust that Neil talked about before, if we can see in real timely basis the actions that are being taken across the system, as well as what we can already see, which is the actions being taken within Royal Cornwall Hospital, NHS Trust and SWAS. There's a huge amount of information available already. So I'd be looking for your thoughts, if that's okay, on what else we could do to help you and the committee undertake that scrutiny function.
Before I come in, has anybody got a soft top BMW? And D22XZH?
That's me.
Yeah, and AX53ROH. Yeah, can I just talk to both of you outside just for a second?
We need our car keys.
There's been an accident, so there's
Okay. Thank you for that, Steve. Rachel, is there anything from a NHSE region perspective you'd like to add about how things are going from our perspective?
No, I mean, I think our observations are, as you acknowledge, that the the actions taken were by the system, and I think, you know, it was positive in that respect, and I think you've articulated all together this morning, Vincent, the actions that were taken, the fact that the system didn't go into the highest escalation, and that's not a subjective, that's now done on an objective measure of scoring, so it's comparative across the region. I think Steve's point is right. I think the danger now is that we all suddenly sort of step back because we've done Christmas and we've done industrial action, and actually you need to continue now to build the momentum. And I think Kate articulated an excellent list of things that now need focus. There is stuff in the plans that needs to be delivered on time, and I think the continued confidence that we'll have in the system working together is about the delivery of the existing plans and the commitments that have been made, as well as anything else that we can think of to do in terms of the, you know, what is a very challenging environment. But undoubtedly, I think we've seen right across the board that sharing of risk was, I think, something you should be really proud of, actually, because it didn't happen in every system, and it was significant.
Hopefully leave us on a high, so keep us higher if you can.
So it is high because it's hopeful that there are things that we could do.
It's very optimistic.
So one of the roles of the ICB is to look across the whole piece of everything that it is that we could do. And I do think there is significant opportunity for us around discharging, getting the pathways right based on the risk tolerance of the receiving people rather than the referring people. So I think that is the next place that we should go for a significant system improvement that will allow our CHT to go back to being what it needs to be, the acute hospital for acutely unwell people in the county. So I think from a hopeful sign, I'm sitting here looking at what we're doing, knowing we could do something else. So that needs to be picked up rapidly.
Okay, thank you. So, Emma.
It's just worth on that point, Chair. Just we've got the go live this week of the integrated reablement at home team, which is a combination of STEPS and VCSE organisations. So it'll be interesting to see, and that's in reach into RCHT on towards, with great collaboration from RCHT providing really useful data. So I'm really excited to see what that's going to show us over the next couple of weeks.
And I would quite like for people to be able to, if they see somebody that they think looks like they should be able to go home, to be able to ask the question. So we asked RCHT before Christmas to go to their clinical support services to look who's waiting for the outcome of a test or waiting for something you could have as an outpatient. We've asked the same thing of UHP, because part of the community responsibility should be to support both cohorts of patients, because you don't need to wait in a bed in a hospital. So I think we need to do more of that, not from a critical viewpoint, but from a how can we emancipate capacity viewpoint.
If I bring Sanj in, I'm just reminded of the fact, just looking at my emails here from a couple of days ago, the West ICA, Juliet Ferris, who joined us a little while ago, when we talked about rolling out the Brazilian model, they've recruited 22 workers to focus on Cambourne and Redruth, covering the 4 most deprived local super output areas in the county. That's got to be some assist to this whole process. Yes.
Can I just come directly in on that? I think you're absolutely right. And I've just said to Emma, surely we can use some of these community health workers actually to be doing some door knocking on people that have been sent home. But please not the Brazilian model. Please community health workers.
We're running out of time, but I'm sure the centre and the north and northeast need to pick up on this as well. But Sanj.
Yeah, just coming back on Steve's point, I mean, the conclusion in the FPCC is that Kate and team will go away and come back with a plan around how do we create consistent data that we're seeing from RCHT across the system to enable exactly that. So that is something the committee's asked for, and any support you can provide to Kate and team to do that in terms of how RCHT has done that, how the system more widely can do that, would be appreciated. I think just on the wider point, I think that longer discussion on the winter plan would be really helpful, because certainly in the FPCC, again, we've heard anecdotally of the benefits of the collaboration that led to the really hopeful results we're seeing. How do we capture that, replicate it, continue it, as Rachel said? And I think on the point about discharge that Kate's making, that's exactly where we need that wider system data that you're calling for, Steve, that enables us to think about the risk that's being taken on by those receiving as well as those discharging
Thank
as
you.
well.
So
Yeah.
I'm actually going to move. It's all right with everyone. Unless there's anything really important, I'd like to move us on to the recommendations. Is that all right? Yeah. I'm just conscious of time. Now, as we don't have a paper, I'm going to make a few recommendations, if that's all right. And the first one is to actually reach out to everyone in the health and care system across Cornwall and the Isles of Scilly, for us to actually register our thanks for the huge amount of work they've put in and will be putting in over the next period of time. So I hope you'll support that as we go forward. And I think there is a whole direction of travel in terms of the way in which we work at community and place level that everyone is endorsing. And that's why I started this discussion really with Neil's sort of committee summary, that unless we do this collectively and across place right the way through to the way you described it, Martin, in terms of the pyramid with RCHT, unless we do this collectively and together, we're going to really struggle. But it does look like there are green shoots of things working here. I would, if it's all right with you, Kate, to make sure that both at our February board meeting, we have an even more granular deep dive into the winter plan, along with the budget, and that'll help us focus on the next year. So are you happy for us to leave it at that? Helpful conversation? Lovely, thank you. So let's move on to the next item, which, Rachel, if you could introduce, we've got the paper, we've read that, on the smoke-free pledge. How would you like to take us through this?
Thank you. Just in terms of context, we had a full discussion at the Joint Health and Wellbeing Board about the work that goes on in Cornwall and the Isles of Scilly to move towards a smoke-free place, and there is a Smoke-Free Cornwall Alliance which leads that work. This particular paper is in relation to the NHS work around a smoke-free pledge, and I think it fits in the context of a really exciting sort of new public health legislation around smoke-free generation, which is really aimed at stopping the start of smoking, and will, we hope, introduce legislation around raising the age of legally buying tobacco products, and really, hopefully tackling the issue of smoking and when people start, because it is a hugely important issue for our health. We have 1 in 4 cancer deaths are directly attributed to smoking. 9 out of 10 of chronic obstructive pulmonary disease is related to smoking. It's the largest sort of contributor of deaths in respect to that. So, and also inequalities, which is why it's so relevant to discussing here at the ICB in terms of one of our core purposes. So this particular paper, I hope it's quite clear in outlining the harm from tobacco. And I think it's outlining again the content of the NHS Smoke-Free Pledge, which asks, and it has sort of 8 elements of that, and asks that the board support the sort of implementation of those pledges. And they are quite specific to commitments within the trusts around treating tobacco dependency, which is a programme that supplies stop smoking services and nicotine replacement therapy to patients that they are in contact with, but also embedding a whole system of training, a whole leadership sort of commitment and awareness of the harm to tobacco in a long-term approach. There is some financial support that's already in the system around this, which we expect to continue, but it does need that sort of focus. And we do assume that this will be part of the forthcoming major conditions strategy as well. So this should form a whole part of approaching the risks, and clearly we've already identified respiratory as one of our clinical pathways that's important for the sort of future working of the Integrated Care Board. So lots of reasons why this is a really important bit of work. It's complex. I say this particular paper is around what the NHS contact with patients can do and the opportunities there, and the rest of the work, as was discussed at the Health and Wellbeing Board, includes things like tobacco control in the community, the offering of smoking cessation supports in primary care, the role of pharmacies, the role of trading standards, the work in schools. So this is part of a whole system strategy. There's no silver bullet, as we know, but the change takes sort of everybody's effort. And I think in terms of the outcomes we could achieve, smoking and the reduction of smoking is going to be one of our key opportunities to reduce inequalities and some of the pressure on health services as well, and outcomes for for our residents. So I think a really clear case, I hope, in the paper. We know that CFT have already had a discussion within their board, so I'll ask Debbie's reflections on that. And we have spoken to RCHT around their discussion for their specific organisational sign up as well. So this is an ask for the board to sign up to the NHS Smoke Free Pledge and support the work of the Cornwall Smoke Free Alliance, and then for each organisation to be supported to sign up to the commitments of the Smoke Free Pledge. And the 8 specific commitments are on page 7 if you wish to see what that actually means in more detail.
Okay.
Thank you.
Thank you so much, Rachel. Tom.
Thanks, Rachel. I obviously really support the paper and the proposals, and the huge cost that smoking has to the system, but also to people as well, and the inequalities that exist within that. Just a bit of an offer, really. It would be really great to join up this work with the community health workers and the hubs, particularly in the core 20 areas. You know, very often we see these things as non-binary, as binary. You're either a smoker or you're a non-smoker, and for a lot of people, it's much more of a transition. For that personal indication, it took me 10 years to stop smoking. Okay, so actually, how we can actually build on trust-based relationships, on peer support, to get things to move is really, really important, and that has to come with non-judgmental service framework. So as I said again, the offer is, I think, to go through Emma through the hubs and the community health workers teams to look at places where people feel comfortable and a bit more trust, and perhaps a bit less judgment, in order to be able to push those margins. Would be really great to talk more.
Good. Okay. So let's move to the recommendations, if we may. Oh,
Sorry,
Steve.
if I could just make a couple of comments, if that's okay. Really helpful paper. Strongly recommend it. Royal Cornwall Hospitals NHS Trust Board's considering it in March, and I'm mindful that individual organisational boards will be considering this. So I think UHP and SWAST are both also reviewing that, and I think that's already been the case for Cornwall Partnerships NHS Foundation Trust. So I'm mindful, John, and I do intend to support this in the ICB board. There's a separate process to work through from a Royal Cornwall Hospital Trust perspective. I did just want to observe 2 things, though. One is the challenges that some providers will experience in terms of managing the risk of violence and aggression, thinking about smoking access for ED patients as an example. That is a process that we'll need to manage through carefully. And if what we interpret by a smoke-free pledge is moving to zero smoking on all sites, which, whilst it isn't described that way, would certainly be my understanding, we'll need to manage through those aspects carefully. The other one is the financial implications, and there's nothing in this paper about the financial implications of the costs of this intent. And I don't raise these, Rachel, to suggest that I wouldn't support this. I absolutely would. But there are a number of staffing costs, therapy costs, and there's a lack of clarity on the future intentions from the NHS perspective in terms of funding nicotine replacement and other costs. So just mindful of the financial pressures that we face now and going forward. And I think we should have an awareness of absolutely the longer term demand benefits, which I think is the overriding factor here that should inform the board. But the interim costs that might be experienced in the financial environment that we're in as well. But with those comments, I am supportive of the proposition to collectively sign the smoke-free pledge.
8, because this is the thank you for picking up on that. This is the ICB's position on this. Okay, you support this?
So I think I don't see how we can't support this. And I'm fairly sure that all NHS sites went smoke-free about 20 years ago, because I was working with the high secure estate at the time. And if we're worried about violence and aggression in ED, then in the high secure hospitals, when we were saying there'd be no smoking in them at all. In fact, I think it was even judicially reviewed about whether people could smoke in the high secure hospitals or not. So there are places that will have already done this that we can learn from. I think there is something really helpful about having a blanket ban so that people aren't doing ad hoc challenges, which means that individuals doing the challenge get shouted at. It's something that is there for everybody and is just completely applied. It means that for the peripheries of your site, Steve, the neighbours will get cross because of where people will go and walk to in order to smoke a cigarette. Penventony Lane, for example. But the philosophy behind this we have to accept. I think it would be helpful for us to do a cost-benefit analysis as part of the allocation of funds next year. So the respiratory work should have this baked into it, shouldn't it? So we will pick that up as part of the respiratory programme of work. And yeah, I absolutely endorse it.
So,
Sorry,
yeah, go for it.
just add something. I noticed is it recommendation 4 that talks about spreading the messages, and of course Kate's just very clearly stated this as an NHS responsibility at the moment, but I'm thinking that smoking has a causal effect if you're 4 times more likely to suffer from sight loss through smoking. And with the introduction of the responsibility of optometry to us, are we then sharing that messages through some of our key providers? Would that be a direction of travel?
All commissioned services, I would assume that we would be wanting to sign up.
Because there's an opportunity there,
Yeah.
I think, particularly through optometry, to spread that message about the causal effect.
Thank you. Please respond to that and then add your observation, please.
Thank you. I mean, yeah, one of the pledges is to provide consistent messages about harms from tobacco, and I think that would cut across most specialties. Or so there is that sort of comms, and I think there will be a growing consistent comms as part of introduction of smoke-free nationally, which will be really important to use. Just on the sort of funding and the challenges around that, I think this is a bit of a test of our channel shift, because it may be that all costs for nicotine replacement therapy aren't covered within a baseline contribution. What do we think about that? Cost effectiveness is really clear that would be still a good thing to invest in. So I think your commitment to look at that in terms of next year's financial planning, because it does contribute towards the prevention of the health inequalities and demand. So welcome that, and attest to the system that we could do that, rather than say, well, marginal amounts of money can't be found. And just to really sort of flag as well something I didn't mention, which is we have in the Southwest one of the highest rates of smoking at time of delivery. We have really persistent smoking, in that group of women. I know there's more we can be done with maternity, but that doesn't really give a good picture, does it, for Cornwall? And that does take a whole sort of systems approach to tackling that. So I really hope that we can progress this next year. Really thank you for the support from those NHS organisations who already discussed this, and the response that I've had today, because I think it does take a system leadership approach to really tackle this.
Thank you, Steve.
A couple of comments. The opportunity here for a consistent approach across every primary care, GP practice, every pharmacy, every acute hospital, community hospital, every site that we provide healthcare, I think is hugely powerful. And I'm sure we'd be able to do that, Ali, alongside a council intent as well. And then we start to really harness the impact of a huge workforce to influence change. So I think there is a really significant leadership opportunity for the integrated
Just
care
building
board.
on that, Rachel, we've got Stuart here. So what are your thoughts in terms of picking up on how this is going to work across our GP services and elsewhere?
Part of the work of the Smoke-Free Alliance is to work in that partnership approach, and I know that there is representation from NHS organisations. I would have to check around GP specifically, but they are participating in Stop Smoking services, so they provide, not all of them, but they opt to provide that as part of a local enhanced service. I think fair to say we're talking with the LMC about where that isn't provided, what other options would be
I didn't know
available
that.
at
Very
the
good.
moment. But that's been available for some years in Cornwall.
Thank you. All right, everyone. Thank you. Really important. Okay, let's move to the recommendations on this paper. The two recommendations are, and this is for the ICB. Let me stress that we, as the ICB, sign the NHS Smoke-Free Pledge and support the work of the Smoke-Free Cornwall Alliance. Everybody happy with that? Yeah. And therefore, to build on that, the ICB to support local NHS organisations to review their commitment to the NHS Smoke-Free Pledge. They've got to make their own decisions, but we would support you reaching out to doing that. You happy with that?
Can I add an amendment to that?
Before you do, you wanted to add something, Kelvin?
I was just going to add, in terms of that support, whether we ask organisations how they think about, they plan their approaches to it, because obviously following from a pledge, you need a plan in order to bring that change.
Do you want to pick that up then, Rachel? Okay, do you want to?
Yeah, I was wondering whether there are 3 place-based leaders could tell us about how they'll be implementing this within the places that they have a convening role across, because it'll overlap with some services, but then it gives us a clear place focus.
Okay, thank you, Rachel. Thank you, everyone. You know what I'm like for time. We are running a little bit behind, but bearing in mind we spend a large proportion of the morning talking on performance and the winter. And still a bit of this afternoon's part 2 to make it up, if that's all right. So thank you for that. So we move on to item 10, which is to do with the Health and Care Campus St Mary. So again, a little bit of an apology in terms of a late paper. It's a shame that our CFO has not mended
He's on his way.
his vehicle, because there is some need to make sure that we're all happy with the paper and the letter of support. I think that's probably, but we got there. So Debbie, if you could, bearing in mind we have Scott from the Council of Isle of Scilly on the call. We've read the paper. If you could be as concise as possible, I'd be very grateful.
I will be, but you're going to have to forgive my slight excitement.
Yes, no,
John,
do not let, please.
because-
You understand up.
Yes, I have to say, certainly for a number of us, including Scott, who good to see you, Scott. Happy New Year. This has been such a long time coming. It's been such a long time in the making, and it's not currently in the bag, colleagues, but it is with optimism that we are travelling. And on the one hand, I apologise for the very, very late paper. On the other, it is a demonstration of how close to the wire we've been working to get this through. We have agreed to present the high-level proposition in public today because we think it's such a good news story for Cornwall and the Isles of Scilly. Our CFT board only had chance to review the short-form business case, which contains greater financial detail, at its private board yesterday. So hence the reasons why this is close to the wire. But we could not wait another month, because colleagues can see from the timeline in the paper that the available funding for this round is, one, capped at under 20 million. The second thing is we have to spend the money by March 2025, and that means that we've got to accelerate these proposals. But believe you me, the minute we got the call to say, would we like to blow the dust off of this and try and get this back in front of the approvals processes, we were very, very committed to getting that indeed done. The history is in the paper. The proposal is outlined in the paper. In order to meet the timeline, but also in order to provide us as much certainty over cost as we can, the programme has been divided into 3 phases. One is the enabling works, then there are the modular units, and then there's the reconfiguration of the hospital. So it is a different proposal to the ones that colleagues would have been involved in 2021 and in 2016. But nevertheless, the principles of the co-location of the care home on the islands with the hospital, with an intermediate care facility between the two, the co-location of the ambulance service together, means that we will be able to work towards an integrated care delivery model. And it means that the experience for people on the islands will be much improved and integrated. For the next phase, we have secured the services of Stuart Maitland-Knibb, and thank you, Kate, for the introductions. And he's a professor with considerable expertise in remote and rural medicine, and he'll be working with us on how do we truly stretch our thinking to maximise the opportunities that digital and technological advancements provide us with, so that we can absolutely push the boundaries of what is possible in terms of remote assessment, remote treatment between the hospital and the mainland, but also what can we do between the off islands and St Mary's with enhanced technology that keeps people closer to their own homes as well. In terms of the modular units, wanted to provide assurance these are not porter cabins, these are high quality modular units with a minimum of a 60-year lifespan, which is what we would tend to build units for. And I'm extremely grateful to Scott and Anita, who is our service director for the West, who have been working together closely in terms of the steering group and bringing together these integrated plans. And we will also then need to be working through in due course, once we get these approvals, what the ultimate model of care will look like, because that will of course involve us in staff engagement and consultation around different ways of working. But needless to say, John, I can't go into the commercial sensitive areas of this, but one key thing that we are requiring of this is, because of the extraordinary circumstances of providing a new build in an area such as the islands, it makes absolute sense for this to be considered as a grant, so that we don't fall into the what they call the CDEL limits, and therefore then the revenue consequences, which would then make the overall running costs a challenge for us. We have got NHS England support for that direction, as we have also got NHS Property Services support. So in the light of travelling positively and hopefully, I would commend this proposal to you today, to ask that you support this proposal through the letter of support that's in the appendix, noting the additional paragraph, which is of critical importance, not just to the ICB, but also to CFT and others. So if we, with a fair wind, get the supports that are lined up, we'll be going to council on the 23rd of January, scrutiny on the 13th of February, and full council on the 23rd of February. Once we get NHS approval, we would then be poised to start the groundworks on the 1st of May 2024, with a view to this facility opening in April 2025. And I can start smiling now.
In order to introduce the paper, if I can just say, I'm always happy to travel positively and happily with you, particularly on topics like this. Andy.
So I'm in full support. What an exciting project, recognising the critical risks, but I think that's covered off in the letter. I'm not cited on the detail, Debbie, so this is probably not appropriate for part one. What I don't see is the link to the island's general medical practice, and maybe could I facilitate an introduction to a conversation about how they're involved in this project?
Can I perhaps cover that off, Andy? Yeah. So we work really closely with Anne Cayley and the practice, and this development will mean that it's actually right next door, so it's closely co-located. And my last visit to the island, I had the privilege of going with Kate, and we had a really productive and supportive meeting with Anne, and there will be a cover link between the primary care centre and the hospital, but also it enables them to actually have greater efficiencies, because the care home residents will be on the same spot effectively now as the hospital. They'll be much closer working, so they are with us and in support.
Respond to that?
Yes. So the really exciting thing for me isn't the building, it's the fact that it's the opportunity for us to develop a truly integrated workforce on the Isles of Scilly, and that's health and social care integration, and across the whole bandwidth of health. Stuart Maitland-Nibb's a professor in rural and remote medicine, and his specialty is team-based training. So we have an X-ray machine on the Isles of Scilly that we can't really use except when our CHT staff come over. If it's wet, windy or stormy, and it can be 4 weeks before your fractured ankle's diagnosed. So part of what Stuart will be looking is what we can do with the digital offers we've already got, what we can learn from the military about what they do to risk manage, and then how we make the Isles of Scilly best in class for integrated health and social care. And Scott, that's why you're so excited, isn't it?
So before I move to Steve and Nick, Scott, I'll bring you in, and I take it that we didn't wait deliberately for Paul to leave before we did this. All right, so Scott, how would you like to respond?
Yeah, I think, I've been 6-7 years now going through this process, and it's really exciting to get to this point. And we have spent the last 4 or 5 years bringing two services together, so they are more aligned than they have ever been. And I think the future is going to be really exciting if we can pull this off and we can move forward as an integrated health and social care service.
I'm sure we will pull this off. Steve?
Oh, I'd echo that completely. Congratulations! What a fantastic development, and I agree with Kate. It's not about the buildings, but it is really positive to see this kind of investment coming into the region. And John, we're at the start of the financial year, sort of the new calendar year rather. Neil has challenged us before about, are we serious about place-based working, and what does that look like? And what I see is a £20 million investment in the Isles of Scilly at St Mary's Hospital. A nearly £10 million investment in West Cornwall Hospital outpatients department, and a fantastic St Austell Elective Care Centre development, nearly £50 million of investment this year on the Isles of Scilly in West Cornwall and St Austell. And I think they're really fantastic examples in each case of integration, innovation and providing care close to home. So it just feels like that sets the year ahead in a really positive way.
Kind of summary.
Sarah from the comms team at CFT is really excited about doing something big and bold on this one, so we'll be supporting her to do that.
Thank you. So we're going to go Nick and then Neil.
So thank you again, massively supportive, fantastic, looks great. Again, sort of echoing Andy's comment, community pharmacy, you do have one. They are involved in prescribing pilot funded by NHS England, so a highly trained practitioner. And then just picking up with that also then needs to go. It's great having a fantastic facility, but the workforce plan of what that looks like for people to do, I think shouldn't be lost in this. And actually, if you've got a great facility and a world-leading place to practice, that should hopefully attract that workforce. So, just building in the total assets the island already has, how you totally integrate, and then working that forward. Thanks.
Thank you. Neil?
And I'm thinking about opportunities here, both in learning from the remote island and Stuart Maitland's type approach, which I'm sure could benefit both perhaps training opportunities in terms of the sort of risk issues we've been talking about that could be transferable to some parts of Cornwall and the more remote parts of Cornwall possibly. And also I just wanted to thank you that in the design is something called a non-bed care home space, which I think is instructive and enlightening and is the right thing to do.
That's the influence of our colleagues, Scott and team.
Really supportive, like everyone else on the project. Just a note of caution is the start of the paper about Treasury's insistence around on time, on budget, and then the risks highlighted, the risk of going over budget and wondering where, if it does go over budget, where would the funding be found, but also around accommodation for the infrastructure, for the workers, and also aligning on the design with NHS PS as well. So just a little bit of reassurance, if that's okay, just on are we confident about that element of it? The idea is absolutely great and I do support it. Yeah.
So Sanj, because we're in public session, you'll forgive me if I don't talk numbers specifically, but we were able to, well, our board yesterday, particularly our non-executive directors, were able to quiz the lead for the short form business case, who has been working with Region and with NHS Property Services and our local teams on this. And he feels confident that there is adequate provision across the different phases to contain costs. And also because of the proposal to use a modular build, we've already secured costs, and the tight timeline has in some parts been a positive, because it means that if we are given the go ahead, we're going to be moving in very quick order. So So things are lined up as best they can, and I'm sure Margaret would challenge me if I was giving false assurance here, but our non-executive directors yesterday did feel somewhat assured that appropriate provisions had been made, Sanj. Ultimately, though, the answer to your question is, should there be a cost overrun, that risk sits with CFT.
A minute that. Thank you very much. Town.
Very
Yeah. Yeah.
The questions that came up and had to say the answer is the buck stops here.
Yeah.
Thank you for that question.
Very, very briefly, this is superb and great, and just kind of just looking at the plan. So is mine's a tiny yes and when we're talking about care homes and bedrooms for people, can we look at what potential there is for some shared living space as well? Just because, you know, actually the power of people living together and the social aspect is incredibly important to their health and well-being.
Why don't you,
So Scott on that.
Scott can pick that up.
Scott?
Yes, as part of the plans that was looked at, and some of the rooms within there are able to have double for two people, so they have double beds, etc., and two people can share, husband and wife, etc., or partners. So that was looked at during the course of the that process.
Okay. No, I get that. Can you take that away if you need to, Debbie, as part of the work? So should we move to the recommendation, if that's all right, in a happy and positive way? Now, my favourite phrase, life's about timing. So in a great theatrical way, our Chief Finance Officer walks in just at the key moment here,
Part one.
just to be able to say yes to the recommendation, all right? Because it's important that we've got the CFO's skin in the game here as well. So the recommendation, colleagues, is that we support the project and agree to sign the letter. Now, the letter that is attached to the paper is the one that's actually on admin control and the latest paper that has been issued. So if you need to, just quickly glance at it. But Simon, why don't you just give us your assurance that the appendix letter, you are happy for us as an ICB to sign?
Yeah, after some helpful exchanges yesterday, I'm happy with the letter as it stands, and just the clarity around the grant being provided fully. Thank you.
And thank you, Margaret and Debbie, for that indulgence yesterday. So,
The grant is always our starting position.
Yeah, no, thank you for getting us to that point in the letter. Are you all happy, therefore, for us to sign the letter on our collective behalf? Done. Delighted, and thank you, Scott and Debbie and Margaret and the team on that. Phenomenal. And I'm looking forward to the comms, Lucy, on this. So do shout that one. So let's move on. It's now just gone 10 past, so we're going to be slightly late. Can we just move to the forward plan then, colleagues? So when I look at the forward plan, there's just a couple of things I want to pick up on. I'm not sure we'll be ready for a dentistry update next month. So I suggest we move that back. In terms of the Cornwall plan, Rachel and Ali, that's the...
It'll be Matt Barton. It'll be the Cornwall plan as discussed in the ELB.
In the
leadership board, the Cornwall and Isles Affiliate Leadership Board.
And that's going to be coming in February.
Yeah. If you remember, John, we originally asked for it to come in December.
Oh, it's that bit.
Yeah, it's that one.
Ah,
with
okay,
that.
fine. Okay,
Yeah,
so if
brilliant.
you could be happy with that. Okay, I'm just trying to work out time as well for this, because...
And I think it came to ICP, didn't it? Kate presented it
no,
last
it did.
week.
So I'm very happy with that. What is the LMNS paper?
Maternity and neonatology.
Okay, so that's a key paper. Debbie, you asked for some items going forward. Are you satisfied in part 1 and part 2 that for February you've got cover of any items that you wanted on here? We're just dealing with part 1 here. Because also, I'm just noting everyone, in the orangey type box, there's an awful lot committee chairs for you to pick up and to report in your reports coming through, rather than having separate papers. So there's the CQC self-assessment, there's audit chair report, there's a variety of things here that will be picked up in those committees. So will you please make sure you pick those up? And are we having a separate paper on a Section 75 agreement coming to the February board?
Where it was coming, it's with Simon. No.
So is it included in our financial planning for 24-25? Because if it is, it should form part of the financial.
Are you happy for that?
financial bit,
For it
yeah.
to be done that way? Lovely. In which case, Debbie?
Sorry, John. So just picking up on the community weights in mental health. So I'm assuming that this is a report that's been asked by FPCC, and where it's got the leads. KM is so Kate Maynard's tasked with pulling it together, clearly with our input and support.
Absolutely,
that's exactly right.
And I think that's right and proper, given that we're looking at what our priorities are for 24-25, that we should be shining a light on community weights. And I don't think it's just mental health. I think we should be looking at community weights per se.
What I quite like about the way this forward plan is beginning to evolve is it's beginning to show, Molly and Carolyn, and thank you for doing this with colleagues and Jess, it's beginning to show what should be going through our committees also, so everyone's got transparency who's not attending that committee, that, for example, Debbie, your team, that go, oh, actually, you're FMP, but is my team going to be involved in that? So you're getting sight on some of this. I think we should increase some of the key items that are going through here, particularly in your space and in quality. So what I'd like to try and just get us focused in on next month is, I talked earlier on about budgeting the first draft budget for 24-25 being in play, and so what we've talked about this morning generally is making sure through Sands' FMP committee that some of the high level big drivers of the draft budget go through FMP first before they come here in February. So what I'd like to say, Kate, is that we'll spend a large chunk of next month, because it's an in-month deep dive in terms of this year, but also starting to look like last year. So given the pressures on because of the industrial action and strike, I think if we can have an update on what's happening in year for 23-24, if that's all right, and through FMP, a first highlight view of what it could be for 24-25, Sanj?
Yeah, absolutely. And because that's a priority and we do want to do the community weights and mental health, we may have to shift the environmental climate update to the
fine. Let's do that
following
then.
month. Yeah.
Let's do that as well, because I'd rather have a fewer number of items with real quality debate next month. And from a quality perspective, Neil, I'd like to make sure that you feel that things are being routed through not just FMP, but through your quality committee that come into February, because it's not just about the money. The money is the vehicle. So Neil first, and then Rachel.
Yeah, just to pick up on that environmental climate update, I did ask last month that we might invite one of the team to discuss the work that they were doing in terms of green prescribing and healthy eating prescribing. I'm not going to insist on that, but I do think it's really important that at some point in the forward plan, be it more strategic, that the approach we're taking at place going forward, not just finance, but the issues of the art of the possible by working in primary and community care, which might include that kind of illustration as to why prevention and health creation is the right way forward. So in a way, if the timing was going to be to shift that environmental report, albeit a brief paper allied to a brief illustration of what the art of the possible based on environmental, sustainable health creation type approach linked to primary and community care,
So what
would
I'm
be a
going to
good
ask
thing to do.
for is, and I know this has been, some people know this already, but it's just everyone's cited on it, is that each of the committee chairs, as we go through the next short window, need to come up with their checklists for committees. And I know that Molly and Carolyn, you're working on that. And as part of those checklists, you need to have your own committee forward plans agreed that align to what's happening at board level. So if you want to shift, because don't forget, it's saying here it's coming through your FMP committee. If you want to shift that, because Kate, for example, sits on your FMP and sits on quality, you can also be clear on what's coming through to here as well. So we're joining up the dots a bit on that.
So I'd like our secretariat to make sure that, so Molly and Jess, that we've got our papers going to the right places. Correct. In the right.
That's exactly right.
Can I just pick up Neil's point about the environmental stuff, because the work that Amanda Cadman's doing with general practice goes beyond what people would think as the green plan or climate resilience. So it's fundamentally making different decisions and choices around how we offer care to people in the places that they live. So when we're looking at our clinical reference groups for respiratory, diabetes and cardiology, I suspect the primary care work that's been led by Amanda and her team will be fundamentally part of that. we have only given them funding for 6 months from April till the beginning of September. So we need to evaluate the return on investment rapidly so that we know whether we're allocating more funds from September onwards. I think it would be shocking if we didn't. So we need to bring that evaluation through rapidly.
Okay, so where that's leaving me is if we're collectively agreeing, we're going to try and not crowd out the next board meeting. So we'll try and move as many papers as we can out, and we'll try and keep February, because we've got colleagues from RCHT and CFT joining us, I hope, because there's another in-year kind of conversation that will focus as much of our time as we can on in-year budget, next year's budget, and an update on winter, and spend as much of our time as we can on those items. Not losing sight of the fact that we've got a workforce section that will have Patrick as well next month, and we'll try and focus. Okay, so the only other point I want to raise is, given planning, I'd love to think that for our March board meeting we will have signed off our budget. But bearing in mind it's the second Thursday in the month, I very much doubt it. So I would ask our CFO, would you please try and consider whether we need another extraordinary board meeting towards the back end of March? And if that is the case, can I ask you to get it in the diaries now? Because it also has to be linked in with RCHT and CFT and other organisational budgets as well, I assume, in terms of the journey that it will go through. So,
No, I would say now I very strongly expect that will be the case.
That's
And
why
I
I'm-
would also say there may well be an expectation towards the end of February with an initial submission, so we need to consider that as well.
So will you, thank you for that then, so will you post today, work with colleagues and see whether we need extra, because it impacts not just on our board, but it impacts on others, and we just need to join up the order in which those events actually happen?
Strongly support that. I think if company secretaries can support you, Simon, so that we have that lineup of provider boards and integrated care board. I do have a concern though about whether we will get there for March, and really what drives that is we don't yet have any publication of 24-25 planning guidance, and I don't know what the timeline is, Simon, if we've got any further information as to when we can expect the planning framework to be issued.
I think the expectation end of January now actually, but we have been asked, and I'm picking up with a meeting with CFOs tomorrow and system director colleagues late on Monday to continue with our planning assumptions locally, so we have a framework to work with. So I think we still need to push based on a set of assumptions that we make.
And we have had a note from the national team to actually say press on and do your planning. So we need to take that, and these should be our board's recommendations, and then finessed if need be by what comes down nationally. Mary.
Yeah, entirely support that, and only to make the point that it would be really good to avoid additional extraordinary board meetings in the various provider organisations, if possible, because we've done this before with H2, and it just doesn't give the right tone to the debate.
And that's why, for me, I'm hoping that our February board meeting can be the real high-level base principles of where we're going. It's not that far away, though. That's the reason why I'm raising it.
Can I put some reality lenses into my glasses? I think we are going to have to put in some times that if we don't use them, then we can give people time back. But I think we should plan for the fact that this will go to the wire, because even if we work with the parameters that we've got, provider colleagues won't want to sign up to something till they see the planning guidance. So the reality is we will be working collectively, but we need to put those dates in diaries.
I think that's really helpful. Sorry, John. I think that's really helpful. I'd rather we did it now and took it out than we don't. So let's do that.
That's why I'm raising it now. Exactly. Okay, thank you very much. Anything else on the forward plan? No? Thank you very much. So let's just see where we're at. So it's any questions from the members of the public relating to the agenda? No? Just give it a second. No? Okay, thank you very much. In which case, I'm going to close the meeting at 12:22, so we're 22 minutes late. I'm going to steal 5 minutes out of the break, if that's all right. Just give us 10 minutes. So if we could be back just after 1:30, and then we'll try and catch up the rest of the time afterwards. So thank you very much, everyone. Let's close the meeting now. Thank you.
Thank you, everybody.